In their daily practice, optometrists routinely encounter complex patient presentations spanning physical, sensory, and cognitive boundaries that require a deeply individualized approach to care. This chart shows the current demographic reality in Australia. 21% of the population, or 5.5 million people, live with a disability. For one-third of these individuals, the condition is severe or profound. Despite this prevalence, 12 to 14% of this population actively avoids healthcare facilities due to physical barriers and psychosocial distress. Historically, care for disabled patients relied on institutionalization, often placing individuals in aged care facilities without consideration of their specific needs. The prevailing clinical attitude was paternalistic. Clinicians operated on the assumption that they knew what was best for the patient, which often resulted in zero input or agency for the individual. Managing these cases requires clinicians to dismantle the physical and communication barriers driving healthcare avoidance. The traditional medical model treats the impairment as an individual problem to be fixed. This framework fails when an impairment prevents standard diagnostic testing. Instead, the social model focuses on the external environment, shifting the burden of accommodation toward the surrounding systems. In a modern clinical setting, the primary objective is to adapt the exam environment to the patient's physical and cognitive realities. Applying the social model requires specific modifications to the optometric workflow, starting with communication. Phase 1 of the adapted exam involves environmental setup and history taking, where clear communication protocols must be established immediately. When a patient presents with a carer, support worker, or interpreter, a triad dynamic forms. You must maintain a direct eye line and address the patient directly. Actively suppress the instinct to turn away and talk about the patient to the carer. For patients with autism or intellectual disabilities, speech pathologists recommend using a direct first X, then Y syntax. For example, state first right eye, then left eye. Pitch your questions to the patient's cognitive level by asking about daily activities. Ask what tasks they use their bifocals for, rather than asking blunt questions about their ability to read. Prioritizing the patient's preferred communication method is your primary diagnostic tool for obtaining an accurate clinical history. In Phase 2, refraction, the primary barrier in standard testing is the absolute reliance on subjective patient feedback. The phoropter acts as a physical and cognitive barrier. If a patient cannot communicate clearly, it is difficult to determine if a lens change was registered. Clinicians must pivot to objective alternatives, utilizing visual acuity tools like patty picks or LEA symbols. You must also account for accommodative dysfunction, a common comorbidity in conditions like cerebral palsy and Down syndrome. To prescribe near additions without subjective input, the monocular estimate method, or MEM retinoscopy, is your critical tool. Measure the accommodative lag at the patient's specific real-world working distance. Hobbies like painting on an easel require different focal lengths than reading a book. For very young patients or those who are completely unable to maintain distance fixation, Mohindra near retinoscopy is the alternative. This chart shows the specific mathematical adjustments required for Mohindra. You deduct 0.75 diopters for infants and 1.00 diopter for patients over 2 years old to account for tonic accommodation. Losing subjective feedback does not mean sacrificing diagnostic rigor. Objective measures provide a complete refractive profile when properly applied. Phase 3 is the assessment of the anterior and posterior segments alongside binocular vision. Visualizing and evaluating nystagmus requires specific techniques when standard fixation targets fail. Position a direct ophthalmoscope directly behind an engaging target and interpose a 20D trial lens between yourself and the patient. That 20D lens serves a dual purpose. It magnifies the eyes for better observation, while simultaneously disrupting fixation to elicit the nystagmus. As the patient tracks the target, assess alignment by looking for symmetry in the corneal reflexes, mirroring a Hirschberg test. For wheelchair users or bedbound patients, use handheld slit lamps and mobile fundus cameras instead of a fixed slit lamp table. The clinical tools must become portable to accommodate the patient's physical location, rather than forcing them into fixed machinery. Phase 4 of the exam is management and prescribing. The governing rule here is that the best possible care in a textbook is not always the best care possible for your patient. Prescribing must account for cognitive fatigue. For patients with dementia, single vision distance and near lenses are often easier to use than multifocals. Treatment feasibility must be built around the patient's realities. If glaucoma eye drops must be administered by a support worker who visits at lunch, you schedule the dosage for midday, even if it contradicts the optimal pharmacokinetic schedule. A technically perfect management plan is ineffective if it is incompatible with the logistics of the patient's daily support system. Consider a 53-year-old male presenting with generalized anxiety disorder and severe health anxiety. When it is time to measure intraocular pressure via applanation tonometry, the patient experiences a panic attack. When this happens, do not force compliance or push through the test. You must stop the exam immediately to prioritize the patient. Offer the patient a separate, quiet room to recover, and explicitly state that you can attempt the IOP measurement on a different day. Following the visit, provide clear, concise written instructions and fact sheets to prevent post-appointment anxiety and frequent phone calls to the practice. Acknowledging procedural anxiety and pacing the consultation is a valid clinical adaptation, not a failure to collect data. Managing patients with chronic illnesses and disabilities is not an isolated task. Multidisciplinary care can be formalized using Medicare chronic disease management plans. Utilizing these plans ensures you receive the patient's medical history and treatment goals, keeping you in the loop with the GP and allied health providers. For psychosocial barriers, suggesting a separate mental health care plan can facilitate vital psychological support. Establishing diagnostic rigor and patient dignity through clinical adaptation fulfills the principles of the social model of care.